So now I want to move to mantle cell lymphoma. We have some interesting data. We have a new drug approval in mantle cell lymphoma, which we'll get to in a second. But first, there have been a couple of studies looking at maintenance rituximab in various situations in mantle cell lymphoma. The French group, Legoil, have looked at the idea of maintenance rituximab after an autotransplant in mantle cell lymphoma. And this was an interesting kind of subset analysis where most of the patients were treated with R-DHAP as their second-line therapy, or as part of their therapy before transplant, but a number of the patients, for a variety of reasons, received oxaliplatin. And it turns out that there were some interesting results in the group that got oxaliplatin seemed to do better, which is not something I could say that I would have expected. But your thoughts on this study?
Yeah, it's very interesting. So I agree with you. Like we used to think of platinums are the same. If someone, let's say, fails DHAP, I would not treat them with ICE in pre-transplant setting. But you know, as from the Coral studies, there's data to suggest that if you fail ICE, you can salvage them with DHAP about 30%, which is against what everybody would have thought. So I think the platinums may not be created equal, but this is not just the platinum itself. There's other things with these, with these platinum compounds. But yes, it's interesting because they did not specify the type of platinum needed in the salvage regimen. They just said platinum-based regimen. The majority got the DHAP, some got ICE, and some got the oxaliplatin. Actually, the smallest subgroup received the oxaliplatin.
Right.
So in the subset analysis, it turned out if you received the oxaliplatin, you did better in terms of PFS and overall survival, which is interesting. Yeah. So I think this is a practice changing. I think even though small numbers, you have to give the patient the benefit of the doubt. And I think most of us would use now oxaliplatin-based regimen in the frontline setting.
Great.
How would you interpret this?
Yeah, I think it's as I recall, it was about 35, 40 patients. So it's a small thing. I'd like to study it a little bit more, but I think it's certainly a reasonable thing. I mean, there's no big downside to using the oxaliplatin in the big picture clinically. So it's certainly worth considering. Great. So we've now recently had the approval of acalabrutinib, a new BTK or Bruton's tyrosine kinase inhibitor in mantle cell, and we have a study, really the pivotal study being presented and updated at the meeting by Michael Wang and colleagues. So your thoughts on this drug and kind of where it fits in mantle cell lymphoma therapy?
So that's new data. So this has not been presented before, but the drug is approved about a month ago, and I think the paper may be already in press somewhere. But it's interesting. About 100-something patients with relapsed mantle cell lymphoma treated with the second-generation BTK inhibitor, which is more selective. So we don't expect it to be more effective because it binds to the same binding site as ibrutinib. We expect it to be more safe, probably less side effects. So response rate, again, here, it's very impressive. It's about, I think, 80% had an overall response rate with a 40% CR rate. Now, face value, you could think that, whoa, this is more effective than ibrutinib because the CR rate is higher. One need to be careful because they use different response criteria. They use the new modified Lugano criteria, whereas the old ibrutinib used the Chesson criteria. If you compare them head to head, they're really not a much of a difference, maybe with a few percentage difference. But certainly it's an interesting agent that needs to be looked at with the long-term follow-ups.
Great. And then finally, in mantle cell, our group and others presented, my colleague Gia Ruan, some longer-term follow-up data on the combination of lenalidomide and rituximab as initial therapy in mantle cell lymphoma. Small study, but a lot of careful follow-up. We demonstrated that there was some MRD negativity, and that about 70% of people were still in remission 4 years later. So interesting, obviously non-comparative data. And also I'll ask you, do you think we're reaching a point in mantle cell where we could potentially develop further these non-chemotherapy approaches as initial treatment? I
think we are. I think the paradigm would be, as you'll hear from my colleague Ola, is it's going to be probably following the mantle cell lymphomas. I think we're going to move away from chemotherapy gradually, and we'll use less and less stem cell transplant, I think, up front. That's my prediction. But it's your data is very, very intriguing that you can achieve a 4-year progression-free survival in about 70%. Overall survival at 5 years more than 80%. We used to think the median survival of patients is about 7 years. So this is clearly an option for some patients.
Great, great.